Hello and welcome to Rebelcast. I'm Marco Propersi, and I'm here with my guest co-hosts, Steve Hochman and Kim Baldino. And today, we are diving into the world of street medicine. Street medicine is the practice of delivering healthcare directly on the streets to people who are homeless and unsheltered. Kim and Steve, tell the rebels out there something they don't know about you.
Hi, I'm Kim Baldino, an emergency medicine physician and faculty for an EM residency in New Jersey. Also an EMS medical director for both paramedics and some volunteer ambulance squads in our area.
And I'm Steve Hochman. I am also an emergency physician in Paterson, New Jersey, faculty with our residency program, and I am research director for our department.
Guys, gals, thanks for being here. Today, we have a hugely important topic. Now, individuals experiencing homelessness, they face extraordinary health challenges, and they often live decades less than the general population. Street medicine can bridge the gap, bringing care to those who might otherwise never receive it. And we have two extremely special guests here. First, we have Dr. Jim O'Connell, a pioneer of street medicine who has dedicated nearly 40 years of his life to caring for Boston's homeless population. Dr. O'Connell was the founding father of the Boston Healthcare for the Homeless program back in 1985. And his work is the focus of Tracy Kidder's book, Rough Sleepers. Welcome, Dr. O'Connell.
Pleased to be here. Thanks so much.
Our second guest is Dr. Ed Egan, an emergency medicine physician who represents the new generation of street medicine practitioners. Dr. Egan recently completed a dedicated street medicine fellowship at UPMC Mercy in Pittsburgh, and he's been training under some of the leaders in this movement. And he's now a practicing emergency medicine physician in New Jersey, and he's applying some of the lessons he's learned. Welcome, Dr. Egan.
Such a pleasure to be here. Thank you for having me.
Jim, is it okay if I call you Jim?
Please, yes.
Ed, that's okay if I call you Ed?
Absolutely.
All right, we are thrilled to have you both on Rebelcast, and we're excited to learn from both of you. One who helped ignite this field, and the other who's helping carry it forward. So let's start with the basics. Steve, you're up.
To start off the discussion, this is for both of you, really. What is street medicine and why is it needed? And could you help our listeners understand its origins, its scope, and the impact on this population?
I can take a start at that, but I would warn you that Ed is really riding the crest of this movement. He will give you the more advanced details. But Steve, before I get going, I read doctor stories a long time ago about Paterson, New Jersey, and William Cullen Williams. So as soon as you said Paterson, I want to learn all about what you're doing there.
Okay, sure.
But I took this job sort of by being conscripted by my chief of medicine back in 1985. And it was a Robert Wood Johnson Healthcare for the Homeless program grant to Boston. And the mayor was required to have homeless people say how they wanted to be served. So we had no say in all of this. I was a resident at the hospital and took the job. But they insisted that the key to homeless medicine for them was continuity of care, which they framed in a legal document that they still have this, and I cherish it, which said they wanted not charity care, but they wanted social justice and a continuum of care that went from street and shelter. It's the first time I'd seen that, like that, to hospital, to respite care, and then eventually to housing. So that was the first time I think we became conscious of, we knew what we were going to do in shelters, but we weren't sure what we were going to do on the street. And what got us going, that was just the summer of 1985, and we had an outbreak of multi-drug tuberculosis, 60 cases in one of our large shelters in Boston. Most of the people who got TB didn't come back to the shelter because they saw that's where they got sick. But we had to figure out how to get them their 4 medications every day for 18 months to control this pandemic. It happened to be parallel, by the way, with the AIDS epidemic. The first homeless person to be diagnosed with AIDS was about a month after I got to the shelters in 1985. And so we had these twin epidemics going on, which was nice to have grounding in the shelters where we had clinics in most of the shelters, but so many people were going outside. By the way, I should mention that in Boston, so we're kind of myopic, there is a shelter bed for everybody in Boston, and it's not dry. You can be in any state of sobriety, but there's a small number of people, about 5% or less, that don't come into the shelters for a whole bunch of complicated reasons. But we learned early on that they were the ones who tended to be sicker and more complicated and suffering from huge burdens of co-occurring medical, psychiatric, and substance use disorders. So our first attempt at doing street medicine was really to try to control this TB outbreak. And interestingly, Kim, you had mentioned that you had read Mountains, Bad Mountains, which was one of my favorite books. But when we were struggling with this in 1985, Paul Farmer was actually a student at Harvard Medical School. So he came down to the shelter, which is really only a few blocks from the hospital and the medical school, and was fascinated by this multi-drug resistant tuberculosis that was going around the city, around the inner city, so the underbelly of the city. And the ways we had to take care of it was, I'll never forget, we had a bartender, for example. I had been a bartender for a long time. In all honesty, I think that's where I learned most about street medicine, by the way. But there were several men that would come into the shelter each night, but before they came in, they'd go to the bar. It was called J.G. Foley's, and get a beer or whatever it is they could drink before they came in, because once you're in the shelter, you can't drink anymore. These were old days. Now we could give the medicine to the bartender and he would make them take it before he'd pour their beer. So 7 of the men with TB were completely taken care of by this bartender working in concert with us. And Paul was fascinated by that, as you can imagine. And so we have mused that street medicine in many ways early on resembled third world medicine, what you do when you don't have academic teaching centers, et cetera. So I throw that out there just as the beginning. We learned subsequently that the people most likely to die tended to be the people living outside during the wintertime. And the causes of death were horribly medical, which wasn't frostbite and stuff like it was cancer and heart disease and seizures, neurological things. So the need for care out in the streets became really evident during that first year for us. And so that, I think, was the early part of street medicine. It was very much combined with shelter medicine, though. So we didn't really make big distinctions back then. And it took Jim Withers in Pittsburgh and some others to really begin to define the difference between homeless and street medicine. And I would pass to Ed. Ed, you know far more about this, having worked at the mecca of street medicine for so long.
Thank you for that story. I didn't know that the origins really started as street bartending in a sense. We hear so much of medicine starting in barbershops. And so to have medicine delivered from the bar essentially is meeting people where they are. And that's exactly what street medicine is. We're trying to find people exactly where they are, and then also trying to find people when they are ready to be touched by society or touched by a medical hand coming to them. And that's the most powerful part. As an emergency doctor, we're seeing many individuals experiencing homelessness come through our doors of the hospital, possibly occupying a bed, wanting food, wanting a place to sleep overnight, a blanket. And that's only a very, very small subset of people that we actually interact with that are experiencing homelessness. And so when you actually go out onto the street and you have a backpack full of medical supplies in your back and a little fanny pack or a toolbox or a binder full of medications, the script is flipped. In the emergency department, where we're used to having a lot of control over our situation and having a lot of authority, but in the street, it's much different. It's sitting down next to someone, hearing their story, giving them the time of day, and trying to understand the dynamics between, like, why is that person there? We might not get to that after 10 encounters with a single individual, but at least we're there and we're doing something, and we're helping these individuals just through socks and water and an open conversation. And then going towards what it actually is beyond that. Most of us here are emergency doctors. Nearly everything we do in the emergency department can be done outside. We're talking medication administration, giving out bags of Tylenol, ibuprofen, to removing foreign objects from eyes, resetting bones, all things of which I've been able to do, street ultrasound and beyond. If you can think of it and you think maybe I can do that outside, you can probably do it outside.
So as an EMS physician, we certainly do practice outside, but it sounds like street medicine can really differ from even EMS medicine.
Yeah, I sometimes call this pre-hospital medicine. We work extremely closely with EMS. We need them hand in hand in case there is a medical emergency. But EMS typically doesn't carry a Dremel to shave down people's calluses and their long toenails. But street medicine, we absolutely do that.
So I guess some of the challenges are self-evident given the barriers that people have between themselves and the healthcare system. But from your standpoint, what would you say are the biggest challenges you face in doing street medicine?
There are lots and lots of challenges in addition to the joys. I think the biggest challenge from my perspective, and I'm looking back now over too many years, is trying to distinguish whether you're doing episodic and emergency care versus continuity of care versus chronic disease management versus something else. So there's that lingering challenge. And I think our experience has been, and Ed said it so beautifully, some people aren't going to talk to you for a year or 2 years or 3 years. And then as they get to know you, they'll open up. So what we know about people after 5 years is way different than we thought the first year. So the challenge, I think, for street medicine is how to create what Ed is doing, make it a viable career track, not something you just do as a thing of good work this week or next week or something like that. Not that's bad, but just that I think the challenge is how do you bring that kind of continuity of care? The second challenge I feel is that the more you're out there, the more you realize how very sick people are. And then the more you realize how much we need emergency rooms and specialty care and inpatient care to really manage their care well. So I often think of street medicine as trying to be vertically integrated along the community, but the challenge also is how to be horizontally around the community, but vertically integrated within our own healthcare system so that when you see someone in the emergency room, you don't feel you're alone trying to take care of that person. Or when somebody is admitted to the hospital, there is a whole system to take care of them rather than all of us feeling like we've got the burden of that person's care entirely on our own.
It's a really good point because there have been days where we can see a lot of people on the street and give out a lot of socks and a lot of water and take care of a lot of wounds. So maybe we'll see 10, 15 people on street rounds during the course of anywhere between 4 to 8 hours. But there's also days where I've spent over 14 hours with one individual, just helping that individual through the system in one specific case of identifying early signs of frostbite to then convincing that person that, may I wash your feet? May I take a deeper look? May I see what's actually going on here, while also understanding their entire cultural difference than my culture in how I see this ailment, and trying to infuse both the real true root of this person and why they are staying outside to connecting it with, if we don't get you this treatment, you are going to lose more and more of your foot because this looks like early signs of frostbite. And so trying to help that individual through while having a doctor with them go through the entire process, it takes a lot of time, but it's ultimately necessary to help decrease this individual person's mortality. When we talk about all these public health standpoints, epidemiology of mortality and morbidity on the street, having that opportunity to decrease someone's mortality so drastically by me just being there, by just going there, there is nothing like that. And because I was integrated into this person's care very early on, I was able to take it from initial identification, cleaning the wound, driving that person directly to the emergency department, sitting in the emergency department with this individual, meeting their pain goals, while the emergency medicine physicians that were there would just hand the patient off to me. I was not an emergency doctor per se at this time. I was a street doctor in the emergency department, but then able to advocate for this individual, make sure their pain was controlled, and then getting that person into plastic surgery directly from observation into respite within 24 hours was like nothing else. And it's such a powerful way to get people through a system by interacting well with that system and greasing these wheels of the hospital system so that someone can actually get a positive outcome. And then if they choose to go back on the street afterwards, they can choose that, because street medicine also at its base is allowing people to have free will to live where they want, to live how they want, and us not changing that. Maybe a little persuasion here and there. Wouldn't it be nice to come inside for a little bit, at least for some hot soup? But ultimately, it's their free will. They could do what they want. And if they want hot soup outside, you bet your dollar I'm going to bring it to you.
This really, really is incredible to hear some of these stories. And I just don't think we can thank you enough for the work that you do, Jim and Ed. Well, what I'm hearing essentially is that street medicine adapts healthcare to fit the reality of these people's lives on the street. These people are homeless and they're unable to adapt to the rigid structure of healthcare. And that flexibility and that persistence to stay with somebody for 14 hours, those seem to be the key themes of street medicine. But let's move on a little bit and let's dive into some of these insights from the book, from Rough Sleepers. Tracy Kidder's book about you, Jim, and the world of street medicine. There are so many powerful stories. And the one that comes to mind is your early days at the Pine Street Inn Clinic in the 1980s, and you underwent quote unquote unusual training. And Kidder recounts in the book how Barbara McGinnis told you that you'd been trained all wrong. Traditional medicine had ruined you, and she insisted that you spend over a month simply soaking the feet of homeless patients. And this really struck me, learning to listen to your patients by washing feet. Can you share some of your experiences and what they taught you?
Sure. And just to mention Barbara's name, it reminds me that we owe a big debt to the nurses teaching us really how to care for people. But my last rotation at Mass General, I was a senior in the ICU, and that was June. And July 1st, I was 6 blocks down the street at this shelter clinic. There's 800 people in this shelter. And I thought basically I was God's gift to the shelter. I'm the first doctor to go there, and they were going to be thrilled. I walked into this nurses clinic, and the nurse had been there. They were emergency room nurses from Boston City Hospital who had recognized that they ought to go to the shelter and take care of these people before they got to the emergency room. And they had been doing it for like 10 years, and they were really amazing, feisty, mostly women, a few men. And when I walked in, they looked at me like I had three heads. I have an older sister who's a nurse, so I recognize the look of a nurse when they're not happy. So they sat me down. They said, we're not sure we really want to have you here because you guys are all trained completely wrong. We're trained to go fast, to be independent, to get somebody's chief complaint, examine them, make a diagnosis, get a treatment, and move on to the next person. And Barbara told me on no uncertain terms, if you do that with homeless people, you will never get anywhere. You have to take time. You have to earn their trust. You have to have some cups of coffee with them. You have to really just be there. You have to be present and mostly do just what Ed described. You never judge anybody. Just take them wherever they are. And those were the nurses. And so they took away my stethoscope and all the stuff that I was so attached to and made me soak feet, which is what they did. When people came into the clinic, nurses invited them to soak their feet. They always called them by their name, very gently. Mr. Williams, do you want to have a foot soak? And it struck me then how quiet and sacred that waiting room seemed to be. People were really appreciative of having someone take care of their feet and be nice to them. It didn't take me long to realize that when you're soaking someone's feet, you're a long way from their personal space, certainly a lot longer than the length of your stethoscope, which is what I was usually away from. And the dignity of it was really quite extraordinary. And people were appreciative after you've been walking around all day to sit there and have your feet soaked and taken care of. I also learned a lot, by the way, that I had not learned in medical school or residency about foot care, which turns out to tell you a lot about some of these care, as I'm sure Ed knows, because I think a hallmark of street medicine is you often start with people's feet. That's the entry into the soul. And what I had to do was almost 2 months that they made me soak feet before I could really be a doctor. And the only story I would share with you that you would be interested, I trained at a time when there was no emergency medicine. So when I was training, the medicine folks and surgery folks shared in the care of the emergency room. So as residents, we would have to run the emergency room. We didn't have the luxury of you guys. And what I remember is that this man who I'd seen a million times in the emergency room, who we'd called resistant to care, he had terrible schizophrenia, was paranoid. And in his chart, we had written that he's treatment resistant. And Barbara made me soak his feet for a while, up 2 months actually. And at the end of the first month, I remember the first thing he ever said to me, because he just looked at me with this wry smile. And he looked at me and he said, I thought you were supposed to be a doctor. This is a month drinking my thing. And I looked up, he was the first person that acknowledged I was a doctor in the clinic. And I was like, yes. And he goes, well, what the hell are you doing soaking feet? And I had said something really stupid, like, I have no idea. I'm just doing whatever the nurses tell me to do. And interestingly, he had for years been doing whatever the nurses tell him to do. So he said, God, you're a smart man. And then about a week after that, he asked me for help to see if I could give him something to help him sleep. He hadn't been able to sleep. I'm startled. This guy's asking me now for help. And then I would say within a month after that, he was taking all of the medicines that we had spent 25 years at Mass General trying to get him to take from the emergency room and failing. And so I started to realize, wow, there's something to this taking time, just as he had described in soaking feet. But I kept wishing that when you rate how long was this visit, 10 to 15 minutes, 20 to 30, wish there had been something like 2 months. But I noticed, and one of the curses of all of us in street medicine is that there's no appreciation of the time invested, which I think has a huge return on it, but it's not appreciated by any of our healthcare systems. I think that's one of the challenges. I think Ed would agree that for a doctor to spend 14 hours with a patient is going to be critical down the line. but may look like a pretty inefficient productivity skip. And we have to fight back against that.
Certainly a powerful account. It's a reminder that we really have to earn our patients' trust and respect. It just doesn't come automatically with the title of physician. Building on that, let's talk about some barriers to care for these patients. From your experience, both of you, why do so many unhoused individuals avoid seeking medical attention until things become dire? What keeps them from just going to the hospital?
This question is so complex because there's so many reasons, both systemically and individually. Most people, we don't even know where they're actually staying, where they're living. We have a lot of working homeless individuals sleeping in cars, on people's couches, because homelessness isn't just living on the street. People being rough sleepers where they're on friends and family's couches, they're sleeping in a motel, they are sleeping outside and elsewhere. So trying to find individuals is our first barrier. But then what actually stops individuals from coming in? Most often the individuals that I'm interacting with outside is because of some sort of institutionalized trauma, whether it's trauma with the hospital itself because of being looked at upon differently, because of being looked at upon as just wanting pain medication or just housing, when that's one of the basic human rights. Outside of that, there's also just individual thought that I can still do this on my own, that I have dignity, that I can treat this on my own, when someone may just need a helping hand of someone coming out and visiting them. And as for coming to clinic medicine, then it gets even more challenging because it's people living outside are busy people. They're not just doing nothing all the time. And so we have to schedule time with individuals to know where they will be so that we can then meet them there. And clinic hours don't often have that same flexibility. So oftentimes, if we want an individual to go to a clinic, most clinics will say, okay, they can come in at the end of the day. That leaves a very small window. I'd rather that person try to get there in the morning. And then if they show up any time throughout the day, if they show up, boom, it's a win. But oftentimes, again, clinics don't operate like that. Street medicine, we can operate like that and find individuals outside of your regularly scheduled business hours.
That makes a lot of sense. The system has to bend a little bit for them. One of the more startling parts of Rough Sleepers also deals with what happens when we try to solve homelessness by providing the housing. Dr. O'Connell, your team participated in the Housing First experiment, moving the long-term homeless directly into apartments, but the team somberly called that death by housing. Can you talk a little bit more about that and what can go wrong?
Oh, yeah. I feel a little sheepish in answering this because what I would say is we're not going to solve this problem without getting housing. So we have to have housing. It's the absolutely necessary part of solving homelessness. I think what we've learned is it's not always sufficient. And for the people that end up long-term on the streets or long-term in the shelters who struggle with the most challenges, when they get into housing, those challenges don't just disappear because they go across the threshold of building. And in many ways, they can be magnified or exaggerated in ways that we were not ready for. So I'll never forget when it was for the first 25 years I did this job, 20 years that I did this job, none of our street folks ever got housed because you had to get sober and you had to have the medicine, you had to go through a halfway house or a quarter-way house, and they never made it. And then with Housing First, the studies came out in the early 2000s, there were these low threshold things that said, why don't we house those folks first? The ones who are using the emergency room most, the ones who have been out there longest, and bring the services to them once they get in housing, which I think is still the absolute right way to go. The trick is, though, as we got people into housing, the amount of support they needed could vary from not much to a ton. And there was very little funding for that kind of support. So to our heart, we'd be celebrating somebody who'd been on the streets, so I've known them for 20 years on the streets, gets into housing. It's like jubilation. It's a miracle. They've had a TV, the phone. We had all of the places were kind of nice apartments. They were all scattered site apartments. And then what we realized is that people, after a weekend or two of watching the TV for the first time, learning how to use a clicker and having their own coffee maker, then the loneliness hits. That what happened to them on the streets where they had a community and survival skills and a routine, all of those things became null and void when you went into an apartment. And then you needed a whole bunch of other inner resilience to be able to cope. And what we found is people who had been sober for a while, when they got into their apartment, got so bored they didn't like the reality and started drinking again or using drugs again. Or more pertinently, they became so lonely they got depressed, and we had to really watch out for early depression. We have a bunch of homeless people on our board of directors who were among the early people into those apartments. And I'll never forget the man who was co-chair of our board of directors, who had lived on the streets for about 25 years, got into his really nice apartment far away from downtown, still in the city of Boston. And it was so quiet at night, he couldn't go to sleep. And he would put the blanket down that he used to sleep in outside rather than the bed. And then he went down to our offices and he sat down and he recorded the noise of the emergency room across the street so that he could, at nighttime, play that recording of the sirens and the people yelling so he could go to sleep. And we never thought about it. Then he described and did a video for other homeless people about how he became depressed by the loneliness and the lack of community. So I think when we put people into housing, I think the lesson has been we have to be ready to really support them. I think there's a simplicity to say, oh, housing is health. And I don't want to argue with that, but it isn't always enough to make you healthy. And sometimes it can create its own problems. I hate the fact that it was death by housing, but we saw so many people who died in their apartments after doing well on the streets. It was a vernacular that sort of crept in, and we used to worry about that, making sure this is a person who could be, we weren't doing more harm than good by putting him into housing without the right supports. And I could go on and on, but you get the point. It's critical that we build the housing, but I think we in the health community also have to figure out how to provide the health supports just as we do on the street. I think we have to provide them just in housing, just the same way.
So it sounds like what you're saying is obviously housing is critical for these folks, but it's not a magic bullet, right? It needs to be accompanied by social services and support and lots of things that these folks are going to need when they get into a new situation, which segues into another issue in street medicine, which is like the ethical dilemmas. The book discusses ways in which patient autonomy can clash with what medical professionals think is best. For instance, a patient might choose to drink or live outside even if it's hurting their health. And the book refers to the option of Section 12 or pink papering patients, whereby the patient could be involuntarily committed for appropriate treatment. So how do you navigate respecting a patient's choices versus pushing for interventions that could potentially save their lives?
It's something we all think about on the street. What is the best option? Is the best option do something, or is the best option do nothing? And so I'm not talking about capacity making. So if someone doesn't have capacity, that changes an issue, because individuals on the streets, at times, it's such a fluid in and out of capacity decision making, especially older individuals on the street. And that requires so many extra resources and psychiatrists coming out with this to really have an in-depth discussion with this individual as to, do they have capacity? Is this what's in their best interest? Are we seeing early signs of dementia? And we see that both on the streets and in the hospital too. Someone that's living alone, who, do they really know what's going on? Can they really take care of themselves? So that's, I think, one side of the coin. But if you have someone on the street that doesn't necessarily want the care that you are providing, you believe this is life-saving care. If we treat this now, then you will have life and limbs saved later. And individuals don't want that. That's a challenging place to be, because again, what I want for the individual, whether it be antibiotics or hospitalization, may not be what that person wants. Because if they go to the hospital, they'll lose their spot. They'll lose their stuff. They might be involuntarily committed for another reason. There might be law enforcement in the emergency department that they do not want to interact with, so on and so forth. What do you do in those situations? And I'm in this situation very frequently of, again, do I do maybe something that I probably wouldn't necessarily do if I weren't out on the street and I was in this predicament where if someone doesn't want the care, then I may end up doing something. I may end up taking a foreign object out of someone's eye. I may end up doing a laceration repair on the street, all because it's what this patient wants. And it's better for me to do something that's right on the cusp of, is this, quote, allowable, or is this just what's in the best interest of the patient to act in this sense, and then closely follow up with the individual. I'm not just doing something and then leaving them. I'm still following up very closely with this individual, probably more closely than I would with someone that I send out of the emergency department, because I'm so concerned about this individual and their treatment plan and them falling through the cracks.
I think it says that very eloquently. When to take away someone's liberty for whatever reason you're thinking outside becomes really difficult. A couple things come to mind though. It's easier when you're out there, like we have a team that's out there every day and most nights. So if you see someone now, you're worried about them, you can make sure somebody sees them tomorrow, will see you tomorrow, the next day. If you're only there once a week, then you've got to worry about, are they going to be okay for this next week? And it changes the thinking. But the other thing that was a tough one for me is because of what happened in the 1985, 86, there were so many deaths on the street, the Department of Public Health gave money to have a van go out that Pine Street Inn, one of the shelters, runs. And it goes out every night. It's in the book, I'm pretty sure, from 9 at night till 5 in the morning, every night of the year. And it's a group of amazing people that are full-time who go out. They know everybody outside in Boston. We have probably 700 people outside at any given time. I argued to, let's make this a medical van. And the homeless people jumped up and said, not in your life. They wanted soup and sandwich and things that they need in the middle of the night. They didn't want a doctor or nurse. So I got to ride along, but I had to serve soup and sandwiches and tell people if you need anything, I happen to be a doctor. So it was like a backdoor approach. And it turns out to be probably the best thing that ever happened to us because we got to know people in a non-medical kind of way. And it also let us see what was going on outside each night. And there was somebody I could talk to and say, will you check on him tonight because you'll be out there? And what we found was when I first went on the van, I thought we should bring everybody in, that if they were my mother, I would not allow them to be outside on a 20-degree night with not enough clothing and talking gibberish, right? And then the van folks pointed out to me, if you do that, no one's ever going to say, come to the van. If we're going to take care of people, we got to make sure we get to know them. And I'll never forget, there was one lady who called herself a bag lady who lived in a stoop downtown and used to try to keep everybody away by putting all the smelly stuff around her. That was her defense. She drank terribly. And then one day, and now I would say maybe almost 10 years later, she finally started to accept sandwiches from us at nighttime. And we were like, we made a connection. She's taken with sandwiches. And that was kind of our goal at that point. And then frame shifted another 5 years. She does something, loses it during the day, and the police have to bring her in, and she's sectioned as a Section 12, meaning in the mental health system. And we lost sight of her. And I was at a meeting a couple of years after that. And there she was, all dressed up at this meeting. It was a shelter meeting. She's on the board of a shelter in the South Shore. And I went up to her and I was like so thrilled. And I said, you look fabulous. And it's so good to see you. And she looked at me and she just sort of glared. She said, you effing asshole. She said, you left me out there for 10 years and never did anything. And that has haunted us ever since. She would say, my brain was ill and you just looked at me and said, here's a sandwich. And I think that's something we all should, I think we have to have some humility about. We don't know when it's right or wrong and who should have the opportunity to do better. And I can say we have a full-time psychiatrist on the street, a couple who have changed our lives a lot because they're there all the time. And they would point out to you now, the only people that we've seen who have been severely mentally ill on the streets who have done really well have been those who at some point we had to bring in, but arrange care and get them on medicines. And now they're doing well. And then the question is, do you give everybody that opportunity or not? And it's a struggle. We don't know. We tend to always avoid in any way bringing people in against their will. But in sometimes, I think, as Ed, you so articulately said, sometimes they deserve to be cared for. And what we need to do is do that.
That's great. It's kind of awe-inspiring. It's such a fine balance because ultimately we're really here to do the best for our patients, but you have to respect their autonomy and they're adults. They make choices for themselves, which may not be in their best interests, but it's such a difficult place for us to be as practitioners. So let me take a couple of steps back here, getting into some of the limitations of street medicine. And they go through this in the book. You're often treating the symptoms of homelessness, like illness, wounds, infections, but you have limitations of what you can do for the root causes, like poverty, housing, mental illness. And you refer in the book to street medicine being akin to what you describe as good palliative care. So how do you cope with knowing that your medical care, while it's vital for the patients, doesn't necessarily fix the larger problem of someone being unhoused?
I think, very honestly, Steve, we have to be cognizant with our own selves about what's our role, what's the goal here, what's the outcome. And I think we've gone back and forth about this over the years, and I think every street medicine program has to cope with that. And the goalposts can shift a little bit. But when I first started working, this would be, remember in the beginning, I was working in shelters and on the street and in the hospital. And I remember being so outraged at the societal travesty going on, allowing people to go and get into the spot that I just wanted to rage against the system. And I wanted to I wanted to get everybody out of homelessness and into housing. And then we have the usual humbling come up and said, I'm a doctor, we're doctors, and we're not going to get society to change, at least not overnight. We can join people that have protest. But I've been at it 40 years and it's worse now than it was when I started. We're not very effective at ending homelessness, chronic homelessness, or ending homelessness. But what happens then, I think, and everybody who I think does street medicine has some version of this epiphany, it's you get to know the people. And as you get to know them, they are compelling. And what they deserve is to be cared for. And we don't have the capacity to get them all housed. Some of them will get housed, but most won't in the time that we're seeing them. Most are going to still be there. Think of LA with 50,000 homeless people on the streets. How long is it going to take to get just those people housed? And by that time, there's going to be another 50,000 out. So it's a need to care for people. I think it has to be uncoupled from the solution to homelessness. And I worry that focusing on the solution to homelessness means you're not going to care for them. And the thing that Ed and I will both appreciate a lot is think of, here's a population that arguably has the highest incidence of severe and chronic mental illness of any population we know. And then if I were to say, how many psychiatrists do you think there are in the country who are dedicated to caring for that population? And you can count them on one hand. Okay. And I say that because Mass General actually gave us the salary for 5 years for a full-time psychiatrist on the streets. It was like a miracle. Now they would probably put that money into housing, not into this, because now it's looking at solutions. So I think we all have to be, we all have to come to grips with ourselves. The outcome for us is really what Ed said is you just want to take care of that person for that 14 hours of the emergency, make sure they get through the day and give them the best of care. You're not getting them housed when you do that. It'd be nice if we could, if you're not. So I think that's a goal we've had to, in our own program, have to make sure everybody knows we're not doing this to end chronic homelessness. We're doing it to take care of very vulnerable people who really deserve care. It's a little different.
Yeah, I think that's an important distinction because when you look at the magnitude of the problem, it's just impossible to solve in what's in front of you in the 6 inches or 12 inches in front of your face. And sometimes you just have to take it. It's that old saying, like, how do you eat an elephant bite by bite, right? You just got to take care of the problem that's in front of you. Hopefully what good you're doing is moving closer towards the goal. But I just like to move on, if I may. And I just want to take us into the future a little bit. And I want to discuss where street medicine is headed and perhaps how it integrates with the broader healthcare system. And Ed, coming from Street Medicine Fellowship just a couple months ago, this question is for you. But it seems like there's more and more information about street medicine. It seems to be a bigger movement and it's become more widespread. And there are now established fellowship programs. Can you give us a little bit of a sense on how widespread it is and what established programs there are currently?
Absolutely. I think the reason you're hearing more about street medicine is because we have a lot more individuals that are pursuing it because of the work that Dr. Jim O'Connell has done, because of the work that Dr. Jim Withers has done, because we do have an overseeing Street Medicine Institute that is trying to develop more practices and procedures to try to standardize in whatever way we can the practice of street medicine. Because to me, as an emergency doc, it sounds really sexy that we can do a lot of the stuff out on the street. I get to go hiking during the middle of the day and take care of people using the skills that I've developed over the course of my entire life. It's not just my medical career, it's my life before medicine. How do I talk to people? How do I connect with people through whatever it might be, whether it's like fixing a truck or, how to build a fire. These are all things that come into the realm of street medicine. And so there are over 160 programs just in the United States. California itself has a whole California coalition of street medicine programs. And I think there's over 50 programs in that. There are new street medicine programs popping up all the time, nationally in the United States, but also globally. The Street Medicine International Symposium has been in Amsterdam. It's been in London. It's been in Toronto. It's been all over the world because this is not an individual country's problem. This is a global problem. We're trying to do things grassroots in our own communities with people that just want to care about their local communities and connecting it with the larger network. Dr. Jim Withers, who was my fellowship director and started the Operation Safety Net in Pittsburgh, he calls us essentially like a fungus, that we have all these little mycelia that go underneath the soil and that are connecting to each other. And then these little mushrooms will pop up all over the world. And that's exactly how I feel, because when I'm at my new hospital now. I've been there for a bit over a year now in Elizabeth, New Jersey, trying to find community resources that are already doing a little bit of this kind of stuff, but then building a formalized program, getting policy stakeholders. And I met with residency programs who say, hey, Dr. Reed, we want residents to join your team, your street medicine team. For me to say, I don't have a street medicine team. I'm just a guy that likes to do this and I'm trying to start something. So there is, and then I had 4 different people reach out to me recently about starting their own program and their own residency involvement, because people want to do this. It's needed, but it's also really fun. And I think it's protection from burnout that we see so much in the hospital, in our jobs as emergency physicians and physicians elsewhere in the hospital. Because I am thanked more on the street than I am in the emergency department. The individuals we go and take care of, there is no greater feeling that I have. So there is a little bit of selfishness, I think, in there too, because what we're doing is amazing to get out of the walls of the hospital. We can provide high level care outside and we get thanked for it. And so we are growing brick by brick, program by program, to really try to more solidify our national and global reach. And we just get bigger and broader every day.
Ed, given your background and your training as an emergency physician and now having done a fellowship, how do you think emergency medicine intersects with street medicine? And how do you think we best can work together to solve the problem?
I think we as emergency doctors are in really one of the best positions to go out on the streets with our skill set and to also have the time, because we're shift workers. So I work nights right now. And so during daytime hours, I have the opportunity to talk with my CMO, talk with the vice president of community affairs, and have these meetings to try to establish programs. We are good at advocacy when it comes to advocating for our patients. And street medicine allows us to advocate even more for our patients, because we are now able to go to the mayor's office, to the governor's office, to say, we are taking care of this issue. We need more resources from you. We have the skill set to take care of the medicine. We need more housing. We need more social services. We need more community health workers. And making a great plea from the medical side of things to have that opportunity to actually advocate. And we just have such a cool profession that we kind of get to pull people on that we interact with, that we talk to our consultants. We have infectious disease at our fingertips. We have dermatology at our fingertips to say, hey, can I run a case past you? Here's a picture of a rash I saw outside. What do you think about it? We are good at that. And then when you can do that, it makes more people interested. It makes the consultants interested, like, hey, maybe I should take a look out there. Do you mind if I come with you? And that is growth. We are good at that in emergency medicine. So I keep trying to pull more people onto the boat with us, because it is infectious.
So it's really a win-win if it's done right, both better patient care and less strain on our emergency services, emergency departments. But I'd like to shift to a more personal note about what street medicine has taught you both about doctoring and about life. Jim, in Rough Sleepers, you're quoted as saying that finding the joy in your work comes from the system of friends, both the people you work with and the patients on the street, which breaks the typical professional boundary between doctor and patient, considering them as friends. But it might be an important connection to work with these patients. So can you elaborate on that and share any other key lessons you've learned over the years?
Sure. And I would just start by underscoring everything Ed just said about the connections. And it also, I'd say, just from my own perspective, I often think of emergency rooms as medieval cathedrals right now. Remember, in medieval times, feudal times, any problem in society, where do you send them? You send them to the sanctuary where they will be cared for. And I'm struck by anything goes on outside of the streets of Boston that's awry. The call is made to send them to the emergency room, whether it's a social problem, a violence problem, or a medical problem. So you guys get it. You are the society's front door. And it's probably the worst situation I can imagine. You've got trauma to deal with. You've got serious stuff going on. So to sit with for 4 hours with someone who really needs comforting because they don't have a place to go is not, it sets up not a great dynamic. So I really admire what you're doing. What I would say though, in this system of friends is that first thing was when I first started, and to this day, I've never been allowed to have my own panel of patients. I've always had to share a panel with a nurse practitioner, a physician assistant, and now a psychiatrist and a recovery coach. And we all share equally in the care of our panel of patients, right? And we had to do that because of the drive by the homeless people to be sure there's continuity. So they were afraid if Ed goes away or I go away, whoever we're caring for then has to start all over again. So working in a team, even though that's not what I would have dreamed of doing, turns out to be the best because you've got, in fun times, you can celebrate. When it's really awful, you've got other people to commiserate with and you're in it together. And so it's made the work itself, in addition to everything Ed said about being outside, it just made it comforting to be in a group like that and be in a team. So that, I would say that is part of the community of friends. But also, I think when you go out and you see people so often, you realize that these, and I don't know how to say this without being on the edge here, but we're taught about professional doctor-patient boundaries and all that. And they don't tend to work very well if you apply that to a homeless population, particularly a street population. You have to cross the boundary. You have to share something of yourself. You have to have coffee with people. You have to let them go wherever they want to go without saying what you think they should do. Sometimes you have to give them money. Sometimes you have to give them cigarettes in order to buy into a more important thing. All things that I would never say out loud. Just like giving a bartender medication like that would be illegal. Think of that. You can't do it anymore. So I think those boundaries are part of what keep us together. Blurring those boundaries keep us together. And then the last thing I would say, and I'm thinking of what Ed had said, so when you're working alone in the emergency room, somebody homeless comes in and you don't have anybody that knows them or following all up, then the burden is all on you. And I can't imagine how you bear that because you've already got enough life and death decisions making all the time. But I think when you know there's an Ed or a street medicine person who will follow that person, it gives you a whole lot more freedom to do what you need to do now, but know that somebody will see them tomorrow or follow them the next day. I am a big fan of street medicine being integrated into the mainstream system, not a separate system of care. And I worry that with all the street medicine programs popping up, they often are really wonderful people who are kind of mavericks and not part of the system. And that's what they like. And I admire that. But when people get really sick, they really need to be followed. Our board of directors, who are people who are homeless, many of whom lived on the streets, will say the single most important thing we do is visit and take care of people when they're in the hospital. That's when they're sick, most frightened, feel most stigmatized. And that's when they most want their doctor or nurse or something around them. So I keep thinking they're telling us something with that. Who sees them outside? It's really nice if you could see them in the clinic and also visit them when in the hospital and make sure, just as Ed was describing, like you guys are, you're connected to ID, you're connected to oncology. That's what I think our folks need. So I'm an advocate now. Do you realize that there are almost no academic medical centers in the country that will host an on-site clinic for homeless people or street people? I know of 2 in the entire country. And think of, this is a population we spend so much of our Medicare and Medicaid dollars on, but we don't get our main academic centers to really focus on that. And the street medicine movement, if anything that I cherish about it, beginning to bring consciousness of that. People know these are really sick people. They deserve a much more robust system of care than just somebody who sees them under a bridge once a week.
So a couple of final questions for our listeners who might be interested in medical training in street medicine or are otherwise interested. What advice would you give to medical students or residents who want to get involved in street medicine or care for the homeless?
So I was one of those medical students. I didn't know anything about street medicine when I went to medical school, and I did medical school in Camden, New Jersey at Cooper Medical School, which has a very large population of individuals experiencing homelessness, a very large population of individuals that use drugs. And during my second month there, I found out we had a street medicine team. It was started by someone who is at UC Santa Barbara, and they have an excellent street medicine team. And now more places are popping up that have street medicine programs, oftentimes student-led. And these programs allow medical students early in their careers to get an experience of what it's like to be outside and take care of someone. Now, they need to be supervised and they need to have structure to them, but there are so many opportunities available. There are rotations at different hospitals. UPMC Mercy has a rotation. I think Boston Healthcare for the Homeless has a rotation. There are fellowship opportunities. I helped edit the EMRA fellowship guide for street medicine with a few other colleagues to discuss that there are fellowship opportunities, UPMC Pittsburgh, in Dallas, Fort Worth, Texas. There's a new one popping up in Detroit, but there aren't just street medicine fellowships. There's also social EM fellowships that do have aspects of street medicine in them. So I think the Brown program with the social medicine fellowship, you can also be associate medical director of their street medicine program. At Montefiore, they have a homeless healthcare fellowship for internal medicine, and I believe emergency medicine as well. So these opportunities are out there. You can also just email me and I will connect you, because you don't need a fellowship to do street medicine. You just need to care. You just need to want to do it. And that's all it takes. The fellowship helps you with connection. It helps you with some of these other medical ailments, such as wound care, which is a huge one, but just really getting to experience how different programs are. Because as Jim had mentioned, yes, some are smaller and pop up and are on their own. But then as you see programs growing, you can see that it oftentimes grows with the health system and adds more complexity to it, such as a consultation service. Imagine you're in the emergency department and you're working a busy shift and you have someone there who I, as a street medicine doctor on the street, already know. And I already have a pop-up on Epic that are on my EMR that says, this person's in the hospital. And then I will go see them and see how can we get that individual either upstairs or back outside, if that's what's in their best interest. How can we consult in the hospital, which is, we can also do too, consult services to street medicine that are more robust than our social workers that are working in the hospital, and that already have too many patients on their list to take care of. These are all ways that street medicine will continue to grow and continue to help those in our community. But it all starts with someone caring. And if we can keep that caring going forward, from being a medical student to being a resident to being a practicing physician and starting something, that's what we need. So please come join us.
So to wrap up, this conversation has been enlightening and deeply moving. And we've really learned a lot about the approach to medicine, and that it's personal, humane, and inventive. And I think our key takeaways, it's really important to meet the patients where they are, both literally and figuratively. Listening and trust are the cornerstones of healing, especially for those who've been marginalized. And solutions like housing, they're vital, but they have to be accompanied by social support and a sense of community. And every small act, even washing a foot, offering a sandwich, or showing up consistently, can make the world of a difference in someone's life. And for our listeners, if you want to understand more about this work, we highly recommend Tracy Kidder's book called Rough Sleepers. It brings some of these stories to life, and many of them are some of the ones Jim described here. And I guarantee it's going to give you a new perspective on homelessness and compassion. And if you want to get involved and learn more, we're going to put some resources in the show notes. And a great place to start is the Street Medicine Institute, which has information on programs worldwide and how you might volunteer and offer support to their work. Thanks for joining me as a guest co-host today.
Thank you for having us.
Thank you.
It's been an honor to speak with you two gentlemen today, and we hope our listeners have been inspired and enlightened as much as we have.
Jim and Ed, I have to say that one of the most favorite things in my career is taking care of people who I say are on the fringes of society. It truly is an amazing feeling. And I think it's inspiring to know that there are people like you, Ed, and you, Jim, who are making a career out of this. So thank you really both so much for sharing your stories and your expertise. And again, it's been an honor talking to you both.
Oh, and I cannot thank you all enough for pause, but it also has made me realize once again why we look to Ed as the future for street medicine. And that was really wonderful. Thank you for letting me be part of it.
This has been just incredible. Thank you so much for having me. Dr. O'Connell, thanks for always showing us the way, and hope to keep building on this. So thank you, guys.
Until next time, remember that small acts of kindness can make a big difference in people's lives. Take care.